Good afternoon once again. Thanks for the invitation. Alexia, this topic is very important, the PAD, pulmonary artery disease, and RWDE, thanks to your efforts, thanks to the efforts of clinical pharmacologists. This concept, RWD, RWE, is gaining momentum on the market. Last year, I told you about how pharmaceutical companies use RWD, RWE. Well, unfortunately, I didn't manage to gather all the data for this presentation, but nevertheless, I'd like to just provide you the existing data. Maybe later we'll publish an article on this issue. Well, as for PAD, pulmonary arterial disease or hypertension, well, you can see the incidence rate 1.1, 7.6 per 1 million people. Well, and I should say a few words about the epidemiological data. The data of the French registry are shown here. Well, 15 cases of PAD, and again, 5.9 cases per 1 million of the adult population, according to the American registry. About 50% of patients have the inherited form, and the form of the disease related to the use of drugs or different toxins. According to the Russian registry, idiopathic PAD occurs in 41% of cases. Nevertheless, I should say that the existing clinical recommendations refer to the French data, and the main goal of treatment is to assess the risk of the escalation and the success in achieving therapeutic goals. So that means having patient in the low death risk group. Now let's say a few words about new drugs such as selexipag, which is the selective agonist of IP receptors. Selexipag was registered in the Russian Federation in 2019. Well, selexipag is intended for patients who are naive, and Griffon is one of the largest studies ever conducted on patients with pulmonary hypertension. And again, as for the overall survival of patients with pulmonary artery hypertension, we got safety data as part of this study, and they basically corresponded to the existing profile of the drug. And now let's talk about the SPHERE registry. That's a very prospective register for patients on selexipag in a real clinical practice.
So there were the criteria of inclusion allowed to look at the patients in the condition of real practice. Again, I would like to repeat, there were very many participants, and we could receive data about safety and efficacy. It was found that 75% of patients were females. The median age was 61 years. The median time before the diagnosis and the beginning of therapy was 3-4 years. The maximal amount was 7.4 years. Most patients had the second functional class of the disease. 96% of patients got specific therapy after 18 months. Most of the accessible for assessment patients showed the improvement or stabilization of the risk. After 18 months, 24% of cases showed the improvement of the functional class. 64% showed the stabilization of the functional class of the disease. The share of lethal outcomes did not was not more than 12%. None of the registered cases was estimated as the one connected with the therapy, with the Telexipac. Out of first 500 patients who were included in the register, the majority the pulmonary hypertension was diagnosed earlier, and the severity of the disease was assessed as class 2 or 3. More than 2/3 of the patients received Selexipac for 18 months. And after 18 months, the category of risk remained unchanged, and 1/4 of the patients were transferred to the category of the lower risk. Now let us speak about one more small trial, which was called Exposure. This trial defined the scheme of treatment of patients with pulmonary hypertension. So here we see that the goal of exposure was to describe clinical characteristics, schemes of treatment. The design was, there were 3,300 patients. The only exclusion criterion was age. We cut off the population of patients of pediatric age. There was also a group of control when patients got the drug different from the main group. And at the time when the therapy started, taking Selexipac is mentioned here. So we see that the median age was 60 years, 63% were women. 2.7 years. This is the average time between the diagnostics, and 60% of patients has a medium risk in accordance with the strategy of risk assessment. Half of the patients had idiopathic form of the nosology. So the therapy by Selexipac was started as a 3-part combined therapy in 75% of patients. Totally, only 7% died, and 83% in 83% of cases, death was not connected with the drug. It was just connected with the worsening situation with the pulmonary hypertension. Only 19% dropped out because of the development of other diseases. So exposure was done also in Russia. Two Russian centers participated and but are participating in this trial, and you see this table. I would like to say that in real clinical practice, the therapy of Selexipac was prescribed to patients with the earlier diagnosed disease of the second and third class. Most patients received Selexipac as part of the 3-part combined therapy, and 75% were not hospitalized as a result. What I would like to say in conclusion, at the present time, over 2,000 patients are followed up in real clinical practice by the SPHERE data. 18 months after the therapy by Selexipac, most patients did not change their risk profile, and 25% of patients went to the category of a lower risk. There were very positive data in respect of the lethal outcome risk. 75% were not hospitalized during the year of follow-up, and the safety profile corresponded to the previously received data from the clinical trial. But the final results, I think, will be reported to you during the third conference. Well, I hope my presentation has been short enough.